Well, good day to everyone, and thank you for joining us. I am Bob Blancato, the Executive Director of NANASP, and we're so pleased to be hosting this webinar as part of our work with the Nutrition Resource Center of the Administration for Community Living. Our focus today is to learn important insights on how states are combating older adult malnutrition through the Older Americans Act state plans. This is an important element in a needed national effort to address and combat the rising rate of malnutrition in the older adult population. The largest program in the Older Americans Act is the nutrition program. It is about more than a meal. It is also about nutrition education, so participants know more about how to maintain good nutrition beyond what the nutrition program provides. We so look forward to the information and knowledge we're about to get. And now it's my pleasure to turn the program over to Laura Borth.
Hello, everyone, and welcome to our webinar. I put a few instructions in the chat. So during the presentation, please put your questions in the Q&A. We'll address them at the end of the presentation. And the recording of the slides will be available afterwards. So, without further ado, today you're going to hear from 4 wonderful speakers. Elizabeth Fridley holds a Bachelor of Science in Dietetics from Iowa State. She's a registered dietitian and health promotion director at the Iowa Department of Aging. Carmen Clutter holds a Master of Science in Clinical Nutrition from the Ohio State, is a registered dietitian and Chief Deputy Director, Elder Connections Division at Ohio Department of Aging. Shirley Chao holds a PhD in Nutrition Science and Policy from Tufts, is a registered dietitian, and was the Director of Nutrition in the Executive Office of Elder Affairs in Massachusetts for 32 years until she retired recently. She is the principal at Food Policy Insights. And Maureen Brown is a registered dietitian and nutrition consultant at the Bureau of Elderly and Adult Services in the New Hampshire Department of Health and Human Services. Okay, and apologies if my microphone is a little odd. Not really sure how to fix that at this moment, but I will try to speak up so that all of you can hear me. So today, I will provide you a little background on malnutrition and the role of state units on aging and the Malnutrition Learning Collaborative. Afterwards, we'll hear from 2 technical experts sharing their approach. We'll hear from the Learning Collaborative members themselves, and then we'll have about 10 minutes at the end for questions. So as many of you are aware, malnutrition is a public health issue that disproportionately affects older adults. Malnutrition is highest in the oldest of older adults, those 85 and older. And up to 1 out of 2 older adults is either at risk of becoming or is malnourished. Malnutrition impacts functionality and health. And malnutrition leads to poor health outcomes, frailty, and early disability. Last year was a historic year for the National Survey of Older Americans Act participants. This is an annual survey of older adults who participate in OAA programs and seeks to answer important questions such as, are OAA programs serving at-risk populations, and how well are they doing it? And last year was the first year where they included malnutrition screening questions and food insecurity screening questions. And you can see here from this data from ACL that there is malnutrition risk and food insecurity risk in this population. So these are the screening questions that they used. Malnutrition screening questions look very similar to the MST, and then food insecurity screening questions. So the Older Americans Act nutrition programs have a role in addressing malnutrition. In the 2020 update to the OAA law, the purpose of the nutrition programs, it was added to, malnutrition was added to the purpose, with the purpose being to reduce hunger, food insecurity, and malnutrition. In the OAA programs, OAA requires a multi-year state plan on aging. And baseline research of state plans on aging in 2020, before malnutrition was added to the purpose, found that about a third of plans mentioned malnutrition, but very few listed goals, objectives, strategies, or actions towards addressing it. There is a federal requirement to screen with a determined checklist, and the malnutrition screening is authorized, but it is not required. The determined checklist is a self-assessment for participants to assess their nutritional intake. This is considered a first step or an initial screen to see if individuals can be helped by our services, and is not accepted generally as a malnutrition screening tool. So while the programs are screening here for nutritional risk, is more of an assessment on who can be helped by our services. So as part of the grant that Bob mentioned, we formed a learning collaborative to assist state units on aging in adding malnutrition language to their state plan and implementing malnutrition actions. We had 9 states participate. We split them into 2 groups. Half of them had state plans on aging that were due in the next 2 years, and half of them either already had malnutrition in their plans or their plans were not coming up for renewal for a few years. And we also recruited 6 technical experts who were crucial to the success of this learning collaborative. So group 1 included Maureen Brown from New Hampshire, Amanda Stoss from Kentucky, Kelly Wright from Virginia, Elisa Dickerson from Rhode Island, Kristen Cox from Alaska, Carmen Clutter, Mary Bielzuka, Mary Beth Aaronsberg, and Adam Mosey as technical experts. And group 2 included Leslie Farman from South Dakota, Liz Fridley from Iowa, Julia Crago from West Virginia, Joanna Schneider from Oklahoma, Sarah Koenig from Wisconsin, Christy Gardner from Indiana, with technical experts Shirley Chao, Pam Van Kampen, Jamie Gash, and Ryan Hill. So with that introduction, I would like to pass it over to Dr. Shirley Chao.
Thank you, Laura. I'm Shirley Chao. Can we move the slides? Okay. I'm going to address some concerns raised during this practice. So next, the first question is people say, why we include malnutrition in the state plan? Everybody know malnutrition prevention and treatment is very important. Malnutrition is preventable, treatable if identified earlier. You can support the older adults stay in the community as long as possible if they admit into a hospital, improve their recovery, and reduce readmission. Also reduce caregiver and healthcare cost burdens. However, we need to know screening is unethical unless those at risk will then be further assessed and treated. So people's question is, yes, we do all this nice things you're saying, but there is no funding and we are short of manpower. Why we put this into our state plan? I think during this process, when you are doing the assessment treatment for higher risk older adults, you actually empower and enhance your organization's capacity building for food and nutrition services, and further generate resource or other revenue for your organization. Next. We talk about some steps included when you put malnutrition into your state plan. We are aware is many factors, risk factors, will cause malnutrition in the older adults. So it's no one solution fits all. First thing you do is identify most needed challenge area in your state that can reduce malnutrition risk or raise malnutrition awareness. Second, you study the size of your state, pay attention to the cultural and ethnic population needs, and also the number of AAAs. It makes a big difference if you are a single state's AAA or multiple AAAs. You weigh in your relationship with your AAA and also your working relationship in the past with other state organizations, which one can produce the most effective result. The last one is, I always think, important you assess the nutrition ability of each your AAA. So when you have a plan, you make sure those AAA be able to deliver a desirable outcome you put into the plan. Next. What a lot of questions brought up in my group was buy-in. How can I make the local agency buy in this idea? How can I make my supervisor, make other organization to buy in this idea? So we said, let's turn the table. Let's talk about the healthcare facilities, the hospitals, the ACOs. What do you want from a community nutrition program? So what we got is you can see the risk factors. Those hospital ACOs, they want to see their patients have those risk factors, and they want to purchase goods and the services from you. Goods is a tangible box, medical tailored meals, grocery bag, or food vouchers. They want to purchase your the services. You can do nutrition assessment, counseling, and medical nutrition therapy. And also your expertise can refer to other services. Next. I also put some other goods and services you can offer through a malnutrition prevention treatment program that will empower your program become the community center. When the healthcare facility looking for help, you are there to help and also to generate other resource for your organization. Next. I want to give you a brief overview for the Massachusetts Commission on Malnutrition Prevention. I co-chaired the commission from 2018 to 2022. The website there is have every year's annual report if you want to know more details. So next, the commission has a lot of goals. I highlight some, I'm not going to read through. The most important is data collection, analysis to identify risk, then how to raise the public awareness and how to reduce the rate of malnutrition among older adults. And the last thing is maximize the dissemination on best practice. Next. So in 2018, when we started, we did a baseline survey on target long-term care facilities. And we found out that 60% of them, they do ask the question, but they don't have a screening tool. So as you know, there's no way to identify the number, how many people is at risk or who they are. Second is we did research to determine best methods for raising awareness. In 2019, we did a lot of action. First, we said, let's put a screening tool in the intake form for the new clients. The nutrition program start doing medical nutrition therapy. Yes, no extra funding. So we use the Medicare Advantage and also the CMS funding, try to pay for it. The commission introduced patient PIN technology. So the patient can bring their information from hospital discharge right to the community to follow through. Next. Next. The governor also designated the older marker month to promote malnutrition prevention among older adults. We conduct a statewide clinic, malnutrition screening clinic. We have 82 clinics. We do that in a week. It was kind of fun. The press release leave the name, time, location, so seniors can walk in. Doesn't need to be a meal participant. Any seniors walking in. We want in a very short time to get some kind of prevalence, what the community malnutrition profile look like. 3,000 people participate, and 1,000 was screened. I think Bob actually come to the Boston kickoff. We use two tools. We use the MST, also the Frail scale. If you ever do this practice, I highly recommend the Frail scales. So we found out 10% community living, 33% of homebound. So that in line with the research we studied. Next. So it's come 2020 to 2021. I would say that's the biggest challenge years for malnutrition among older adults. You know, the food insecurity increase, malnutrition increase, people shutting in, isolation, everything. The 2 years we learned the most is collaboration. We are in the Governor's Food Security Task Force. It's a public-private sectors, local communities. Everybody work together, try to link the needs and the services to support the nutrition program. I think the response is on the slides, you can read. But the one thing I do like to mention, next slides, is a social media campaign. We did 4 times. The first one is do a COVID check. Second one is a statewide food assistance decision tree. And the Be a Nutrition Neighbor, we did it twice. First time is raised awareness. The second time is people get scared, lot of fear. They don't want to come out. One thing I like to mention, in one of the campaign in 1 week, we posted 100 times on those images. So we have close to 110,000 impressions to check on that message. So it's in a very short time, we get a message across. Next. In 2022, Commission participated in some national activities and also local. The White House Conference on Hunger and Nutrition Health, we write the recommendations, we participate. We support the CMS Global Malnutrition Composite Score. I know it's for the hospital, but it's very important. That's the first time Medicare recognized nutrition care as one of the quality measure. The one thing is we work with Food is Medicine. We had the inventory taking. We did a survey on statewide. We map out every nutrition program, food bank, pantry, councils on aging, everything, what they provide on the food services. One part is for the consumer, another part is for the healthcare organizations. The result is very promising for the 5 years, even longer efforts on this prevention. So can I have the next slides? Almost done. Okay. I mentioned earlier how you empower yourself. I think the medical tailor meals, as you can see, every AAA in Massachusetts, they are equipped to provide medical tailor meals. And now they provide for the ACOs. They generate revenues, also help the seniors. So I think that's my part, and I will stay on if you have questions. Thank you.
Good afternoon, everyone. I'm Carmen. I am the Chief of the Elder Connections Division at the Ohio Department of Aging, and I'm going to take some time to really build on the advice and recommendations Shirley just shared with you all and discuss how Ohio implemented various nutrition strategies, specifically those to prevent and address malnutrition in our state plan on aging. Next slide, please. So creation of our current state plan has really been a several-year journey that involved many multi-sector partnerships that helped contribute to the development. So we actually started in our last state plan cycle, which was in federal fiscal year 2019 to 2022. And not long after that plan was effective, we really identified a need for a much more comprehensive picture of health and wellness of older Ohioans, and then hopefully some action items to address those challenges. So this led to the creation of our summary assessment of older Ohioans. We published that in June of 2020. And it kind of gets back to what Shirley just mentioned. First, like really assessing the landscape and finding out where our challenges are and what are those things we need to account for. So the summary assessment answered two main questions. One, what was the biggest health and well-being strengths and weaknesses for older Ohioans? And then two, of those factors, what are we going to prioritize as being the most important things to address? And then we use those findings to help inform a very specific prioritized action plan, which we called our strategic action plan on aging. And that was kind of this comprehensive roadmap of how we would move to meeting the needs of older Ohioans and persons with disability within a very targeted set amount of time. So we released the strategic plan in March of 2021. And then in February of 22, we created an implementation toolkit that was really geared towards providing advice to local partners on how they could actually put those things into action. And then all of that great foundation went into our state plan on aging, which is what I'm here to kind of talk to you about today. Next slide, please. So similar to Massachusetts, we also had a Malnutrition Prevention Commission, and it was really formed a few years ago to study the impact of malnutrition as it related to healthcare costs and data, education and awareness, and then prevention. So we were able to leverage these recommendations that came out of our state's commission and integrate them and consider them as we evaluated the need for stronger adaptable nutrition strategies to reach the most at-risk communities here in Ohio. Next slide, please. So Ohio State Plan on Aging has been effective for almost 1 year now. Our state plan spans federal fiscal years 2023 to 2026. So it went into effect October 1st of 2022. And similar to what our strategic action plan was, it really serves as this comprehensive roadmap that's guiding the state's aging network on strategies to advance elder justice and equity, an effort to achieve optimal health and well-being for all older Ohioans. And we know it's really important to have this roadmap in place because from doing our needs assessment, but also all of the work that went into that summary assessment, unfortunately, we know for too many Ohioans, the opportunity for healthy aging is too far out of reach. Next slide, please. So our state plan is a little bit different from our prior years. It might be a little bit different from some of you that are on our call today, but we're really focused on multi-sector partnerships. So going beyond just the traditional aging network space. We know that to truly address and resolve and plan for current and future needs of aging adults and persons with disabilities, we kind of need like the full team effort. We need everyone rowing in the same direction. So, kind of think to yourself, how are we going to solve for malnutrition if we don't ask everyone, even beyond us, even beyond the AAA network, to help, right? We need partners across the whole state. We need partners and advocates that are really invested in making meaningful change so that we can see these health outcomes achieved overall. So our plan's rooted in public and private collaboration. We're asking everyone to kind of align their approach, find some place in our state plan where they can focus or they can work on. And so that's kind of the message that we've really started off with, and just working with different groups who maybe have not been traditional partners within the aging network to, come on board and find their place. Next slide, please. So here we have our framework for Ohio State Plan. Our goal is that all Ohioans live longer, healthier lives with dignity and autonomy, and disparities and inequities are eliminated. So those navy blue boxes that you see on your screen, They are our 6 priority topics of our plan. And within those, we have 15 issues that we're prioritizing. So for example, in the healthy living topic, the 2 priority issues include improving nutrition and improving physical activity. And then at the bottom of our framework are the principles of the state plan, which include elder justice, equity, and then alignment with federal priorities from the Biden-Harris administration. So the topics and issues that are prioritized on this screen, those were identified through that kind of journey process I walked you through. So through the statewide needs assessment, we also had involvement of an expert-based advisory council of roughly 60 or so aging and health experts across the states. And then we did a lot of key informant interviews to help identify where we needed to prioritize our focus. Next slide, please. So I'm not going to go through all of our goals today, but I thought it might be best to quickly review our approach to developing goals, because this is some of the conversations we had as a part of this coalition or this collaboration, was talking about setting goals, but also evaluating those goals. So this is our overarching goal for our state plan. There are 4 outcomes. They all have corresponding objectives in which we can monitor our progress, right? And below each outcome, we develop those SMART objectives. And I'm sure that's very familiar to you all. These are objectives that are specific, they're measurable, they're achievable, they're realistic, they're time bound, they're statements of how we are going to make an impact and where we want to be. So within our state plan, we were very intentional about setting SMART objectives, because we're going to track those progress. And if you take time to review Ohio state plan, you'll see that we've set short-term, medium-term, and long-term targets, and we're going to be able to track that through the data sources that we've identified. Next slide, please. So I'm going to hone in on one of our strategies. This is our healthy living topic. Again, I mentioned that our 2 main objectives are outcomes focusing on improving nutrition and improving physical activity. Next slide, please. Okay, so then from those strategy categories, we really built out our state plan to have examples of evidence-based and evidence-informed programs, policies, and services that have been shown to be effective. And we know that they can move the needle to ensuring that all older Ohioans have those opportunities to live healthy and live independent lives and engage as they want in their communities. So this example, I pulled out one of our specific strategies related to malnutrition prevention and treatments. And this strategy provides examples of evidence-informed or those evidence-based interventions that support that strategy. So this could include expanding nutrition education, or maybe even improving discharge planning. We also included a lot of other resources at the bottom of each kind of strategy page of our state plan that just directs attention to other really valuable resources. And then we also took the opportunity to flag different strategies or programs or services that also aligned with Ohio's health improvement plan, because we know so many of our community partners are also aligning their work with their statewide health improvement plan, or their community health improvement plan as well. Next slide, please. So here's a quick look at our objectives that are focused on improving nutrition. We established 3 SMART objectives that we're going to track our progress. And we identified these through thinking about what data points, what metrics did we have available to us. So when we focus on the unintentional weight loss, we're able to track that progress because it is a state module that's added to our state's BRFIS, that behavioral risk factor surveillance system. So we've set some target points of how hopefully we see this decrease in the coming years. And we're going to be able to track that moving on and hopefully evaluate whether we need to change some strategies or form some more partnerships to see us reach those goals. Next slide, please. So as I mentioned earlier, our plan is really rooted in that multi-sector participation. And, maybe that's a little bit different from your plan. This certainly was a new approach for us. I think in our prior state plan, we really focused on kind of internalizing within the aging network what we were going to do. So this time around, we kind of changed it a little bit and we focused heavily on our call to action. So how can other agencies, AAAs, community-based partners, private organizations, local government, people that are not in the aging network space, how can they get on board and kind of act on our state plan? So we thought it was really important to have this a focus point of our state plan and help to paint that picture. The traditional aging network, we can't do this work alone. Even if you think about malnutrition risk, we need to increase, think about the transportation efforts that need to happen to ensure that there's accessible transportation to food points, to food access points. So it's this really full circle effort that needs to take place. So specifically, we wanted folks to, align their focus, help to advocate for these priorities, maybe even consider funding one or more of the strategies in our state plan for actual implementation. Perhaps consider expanding their partnerships to improve outcomes and then help to evaluate the progress. So our message with a lot of people across the state of Ohio have been that, hey, everyone's got a seat at the state plan table and we're asking you to be actively involved. Next slide, please. So I mentioned we developed a implementation toolkit, and we developed this alongside our strategic action plan on aging, which was kind of our predecessor to our state plan on aging. But this resource provides guidance, best practices, tools, and resources to support partners in responding to the plan, acting on the plan. And we found this to be really helpful in helping community partners align themselves. In fact, we actually heard from several of our senior centers that it was a helpful tool as they started to reopen after the pandemic and kind of reevaluate what their focus would be or maybe what programs they needed to implement. And it really helps to make, I think, the state plan personable. It includes like actual worksheets that help you work through identifying maybe what program you want to implement, what partners need to be engaged. So for example, if there was someone out there that wanted to do one of the strategies focused on food access, we have a worksheet that's going to help them work through questions they should consider. They're going to write down who their partners are. They're going to identify what funding sources they have. They're going to think through what limitations there are. So it's this toolkit that's been designed to help people from start to finish act upon something in our state plan. Next slide, please. And then finally, before I hand it back over, just wanted to point you into where you can find Ohio's State Plan on Aging. You can find it right on our website, aging.ohio.gov. All of the resources I went over today, the publications I spoke of, they're all included on there. And one of the things we love about our state plan is it is best accessible online because there's a lot of hyperlinks that'll take you to even more information. Let's say, again, you wanted to look at the strategies along with discharge planning. You can click the hyperlink for more information and be taken to more details about how you can implement that. So that's all from Ohio, and I'll go ahead and pass it on over. Thank you.
Okay, next we have our Malnutrition Learning Collaborative participants. So kicking it off first is Elizabeth Fridley.
Hello, everyone. My name is Liz Fridley, and I am the Health Promotion Director at the Iowa Department of Health and Human Services, Division of Aging and Disability Services. And like Laura mentioned, I was a member of the Malnutrition Learning Collaborative group with state plans after 2024. Next slide. So I wanted to get started on this work planning to add malnutrition to our state plan now. And having this time to have extra conversations and be thoughtful about how malnutrition will fit into our state plan and integrate into the work being done by service providers across our state. So our current state plan on aging is for federal fiscal year 2022 to 2025. So I am planning for and preparing to incorporate malnutrition into our state plan, which will begin in 2026. So I started by reviewing state plans that have already included malnutrition. I looked at their language, their objectives, their goals, and vision for ideas. Ohio is definitely, and Massachusetts were definitely state plans that we looked at. Next, I reviewed our current state plans, goals, and objectives, and tried to look for places that malnutrition might naturally fit. So for example, to shorten this, but to summarize, we have an objective that focuses on improving the reach of nutrition education and nutrition counseling to older Iowans at high nutrition risk. And I thought that the addition of targeting to older Iowans at high nutrition risk or those at risk of malnutrition would fit nicely. And so I used that as a starting point for conversations with the technical experts that I was able to connect with through the Learning Collaborative. We then discussed state plan language ideas as well as action steps, and they shared a lot of really helpful information about their experiences doing this work. And I believe many of the resources that they shared with me that I was able to use will also be available to you in the toolkit. Next slide. So all the strategies that I've implemented so far really boil down to just consistent conversations. So we've already had many discussions with AAA nutrition and health promotion directors about malnutrition, covering topics about what is malnutrition, what's the difference between nutrition risk and malnutrition. We've definitely shared some of the Defeat Malnutrition Today infographics that highlight the estimated cost of malnutrition. And the intent of these conversations is to build awareness and knowledge of our AAA staff on this topic and get them more comfortable talking about malnutrition. I used the resources that were shared by the technical experts in the Learning Collaborative as a starting point for PowerPoint presentations for more formal calls and conversations, and also just using them as a framework to hold these conversations because not all of the AAAs are at the same spot in their journey, and that is okay. So having these conversations consistently and regularly to meet everyone where they are at now. Again, we have the gift of time with our state plan not starting until 2026. So we're able to go slow and get everyone on board and comfortable with this topic. Through these conversations with the AAAs, we were able to identify opportunities to pilot malnutrition screening in a couple different AAAs. And I'm hopeful that by 2026, these pilots will expand or maybe be implemented in new AAA service areas. And the third strategy that I've implemented up until this point was being able to work with the database administrator to get the malnutrition screening tool, or MST, added to WellSky for optional use. This was a big step as it allows us to start capturing data for the AAAs that are screening, and then we can use that data to make informed decisions. Next slide. Two challenges or uncertainties that stand out so far in this process. The first is we are still trying to develop comprehensive intervention and referral pathways to be able to utilize in response to a consumer screening positive for malnutrition. At this time, we offer nutrition education and nutrition counseling or meals, and I would love to see this expand. And so it's really great to hear from the other states that are farther along in this work, and I'm excited to see what we can put together. The second challenge or uncertainty is how best to capture the impact that the Older Americans Act services have on malnutrition and malnutrition risk factors. So trying to decide what is the best data to collect and how to use that collected data to tell the story of impact. I don't have that sorted out yet, but I do plan to continue to have conversations and collaborate with our data team. And we'll be keeping my eyes and ears open for how other states capture the data and tell that story of impact. So in summary, the work to incorporate malnutrition in our state plan has begun, even though our next plan won't take effect until federal fiscal year 2026. I started this process by connecting with and learning from other states that are already doing this work, and that has been extremely helpful. Currently, the approach within Iowa consists of consistent and regular sharing of malnutrition information and having malnutrition-related discussions to build awareness and knowledge and understanding of malnutrition. We are starting small with malnutrition screening pilots and gathering input from the AAAs. We are going slow and learning together. And I'm hopeful that this approach will lead to more buy-in from partners across the state and ultimately better processes and outcomes. Thank you.
All right, next we have Maureen Brown.
Hi, everyone. I'm going to jump right in. Do you have control of the slides, Laura, or do I?
I do.
Okay, great. All right, next slide. Thanks. So I'm going to jump right in. Our state plan here in New Hampshire is actually was submitted in June this past summer. We are waiting approval from ACL, and it'll be running, our current state plan will run from 2024 to 2027. What I thought I'd start with is focusing in on the background and what informed our approach here in New Hampshire with developing our state plan on aging. Next slide. Okay, so we started with what we learned during the public health emergency. That was our initial approach. And some of the things that we learned that helped inform our approach was we discovered that there was a need for a continuation of grab-and-go meals after the ending of the public health emergency. We also noted that there was a need to respond to changes in service methods and preferences of New Hampshire residents, and that led to initiating the restaurant voucher program. We also noted that there were decreasing trends in participation in commodity supplemental food programs and also the enrollment of SNAP eligible participants. And that downward trend was continuing post public health emergency. What we did get, I just got this information this past week, is we have recent data that shows the first time in quite a while, a slight uptick in the trend of SNAP participation. So as a Bureau, we reached out to our folks that are collecting that data, and we're awaiting specifics on older adults embedded within that data to see if we're reaching them and if they're part of that uptick that we've seen. We learned also that there's underrepresentation in New Hampshire of older adults in programs, coalitions, advocacy groups throughout the state, locally and statewide, and that there's definitely a need for age-specific nutrition and health-related data that's inclusive of older adults. Next slide. So then we asked the question, what was already happening in New Hampshire? The goal was to not duplicate efforts in the state and also to identify who and what we could build on. So some of those, the answer to that question led us to several different things, and those are included on this slide. We found that New Hampshire Hospital Association's healthcare priorities there was a decision made to include the implementation of the Hunger Vital Signs food insecurity screening tool in both their hospital and primary care settings. And that is well underway, and some data is coming back about that. Already underway was New Hampshire Hospital, which is our state psychiatric hospital. Their strategic plan was underway for 2024. And we actually utilized our relationship with them to bring them on board with our pilot, which I'll talk about in a moment. We also found that there's a need for continuation of our interdepartmental food and security work group that was started during the public health emergency, and that included SNAP and summer lunch program and WIC and summer school lunch program, farmers market, AAA, Title III. We're all woven into this interdepartmental work group, and we realized we needed to continue that. And we also realized that there was a presence and growing number of stakeholder groups that were focused on anything from food access, ending hunger, nutrition, health equity, and advocacy. They are really growing and continuing to grow in number and in, power for making change within the state of New Hampshire. So asking those questions, next slide, is the outcome of looking at what we learned during the public health emergency, combined with asking the question of what was already happening in New Hampshire. It led us to develop sort of generalized approaches and strategies. And those included what you see here. We followed suit with Iowa, and we were looking at gathering information from states that already had a plan that contained malnutrition language, as well as those that were planning on it. Kind of helps to commiserate. So we found that really helpful. And utilizing the listserv. Folks that were on our listserv were very, very helpful. Once we did that, we started to review state plans that contain malnutrition and really started comparing those state plans to ours for similarities in structure and content. And that was really to help facilitate us updating our own state plan. So we sought advice of technical experts in the field of nutrition, but also in the fields of advocacy and data collection. And that led to the participation in this collaborative, as well as tighter relationships with the Division of Public Health, which is very, very good at data collection, and also two entities here in New Hampshire that are known for both data collection and for advocacy. And that includes the New Hampshire Center for Justice and Equity and New Hampshire Hunger Solutions. New Hampshire Hunger Solutions is the largest coalition focused on food security, ending hunger, reducing malnutrition in the state of New Hampshire. So we'll be doing a lot more collaborating with them. And then generally in general education, advocacy for nutrition of older adults, and just continuing to expand our active representation in the local coalitions and groups for two reasons. One, so that we can advocate and inform about the needs of older adults and make sure they're represented, but also to receive input and support for older adults. Next slide. So then we took the strategies and sort of made them a bit more specific. And those included short and long-term goals, or immediate goals, I should say. We were looking to achieve uninterrupted continuation of grab and go after the public health emergency ended. That meant the challenge of getting our administrative rule adopted prior to the end of the public health emergency, and we did achieve that. We were also looking to maintain and expand our restaurant voucher program to meet not only the needs of the and preferences of the participants in that program, but also the staffing challenges of our nutrition programs. And I'm happy to report that we have a little bit a snapshot of the survey outcome. This is the second or third survey they've done with the RVP since its inception. And these numbers are pretty consistent. We found that 65% of participants are new to the program. They were prior had no nutrition or food services of any kind, including those from Title III. They also, when they were asked subjectively, what did they find was the greatest benefit that they either expected or hoped to gain from joining the RVP? And over again, we got reconnecting as the number one thing, and that ranged from reconnecting with neighbors, friends, churches, and other affiliates. And also that ended up leading to joining other community activities that either prior public health emergency they were involved in or hadn't even been involved in prior to. So that was really nice to learn. Another strategy was just promoting general awareness of need and understanding of food and nutrition services for older adults. And the challenge in that is really sustaining the collaborations, again, at the state and local level, trying to continue to work with those groups and advocacy groups to keep expanding awareness and keep expanding participation. Next slide. Okay, and again, it's sort of a continued offshoot about educating and informing, but this one was more specific to research and data collection, so we could better represent older adults in our state. So that really is leading to initiating a review, a deeper dive into our state reporting data collection. So looking into that more deeply, if we can expand upon that or add items to that, that is currently underway, as well as working with the New Hampshire Hospital Association and their data collection of utilizing the food insecurity screening tool, as well as what they're doing with that tool, and sort of piggybacking on that. Also working with the Division of Public Health Services. That is where our commodity supplemental food program comes out of in New Hampshire. And then the Bureau of Family Assistance is where SNAP comes out of in the state of New Hampshire. So just continuing working with them as a source of data collection and inclusion. And then another goal was to establish evaluation methods to show effectiveness of the grab and go, moving away from a subjective approach to a more objective approach. So we're looking at trying to track the maintenance and expanding of participation, but also trying to establish a method that would show and demonstrate the reduction of risk of food insecurity and malnutrition. So what we found is that the demonstrating expanding participation is proving very doable, but the latter part, demonstrating reduction in food insecurity and malnutrition, that is going to be more of a challenge for us, and it's one that we're still working on. Next slide. And this is my final slide, which is our final strategy, which is to leverage opportunities to expand participation in the pilot that we're starting here in New Hampshire. This morning, I just got the commitment of our last of our nutrition programs agencies. They were asked to identify a lead in each of their agencies that would be part of this pilot program. And we have 8 out of 10 of our agencies that are going to participate actively in the pilot. And the pilot's focus is to create and implement a universal screening and intervention tools, as well as a referral process to reduce food insecurity and malnutrition risk in older adults. So part of the challenges with that, it's going to be a 2-year pilot, I should say that, and it will just be beginning next month, is going to be maintaining active participation with everyone, ranging from the New Hampshire Hospital, their food nutrition services, and their work around bringing in a food insecurity screening tool, the hunger vital signs. Continued work with our adult protective services caseworkers who have undergone a training and have had the determined checklist and the hunger vital signs food insecurity screening tool added to their forms for assessment and screening. And eventually we want to add a malnutrition assessment form for them and training. Maintaining the participation of the contracted nutrition program staff, the leads in each agency, keeping them excited, keeping them energized. We really need their help to make this realistic, doable, feasible for all our different agencies. And then just fostering relationships in the state of New Hampshire and partnerships, and just keep improving on consistent tracking of the interventions, the outcomes, and the impact that this pilot has.
All right, thank you, Maureen. If all the panelists can come on video. We have one question. Where did you all get the money to do this? From your state budget, federal, or local grants?
I will share where we're at with Iowa. As of now, we don't have any specific funding, like extra funding going towards this. We started looking at where we were already doing something similar. So we were providing some referral pathways and interventions for individuals at high nutrition risk. And so we kind of piggybacked or have integrated or working to integrate the 2-question malnutrition screening tool on top of that, and then following similar pathways as we build out what that maybe more enhanced referral network would look like. So as of now, it is there is not extra funding.
And I'll mirror that here in New Hampshire. There's no extra funding. The pilot is that word leveraging. I never really appreciated what that word meant until looking into this pilot and getting it up off the ground. Again, we're very fortunate here in New Hampshire. There are just so many interested parties. It was right timing. The public health emergency elevated malnutrition risk and food insecurity to such a higher level than it's ever been before. So it was really just good timing for us to just leverage all of that, take advantage of that, and see and reach out, create relationships, and see who we could pull in. And also, like I said, utilizing our programs to help with the pilot as well. What we did make a decision on, and it was a very conscious choice, was to make sure our pilot was 2 years, and it is flexible. We will extend that if we need to, because our goal is to let our providers, our lead contacts, get in touch with us. We're going to have virtual meetings. That's how we'll approach this. Get to know one another and start talking about, okay, here's the options that we have. Here's the tools we're looking at. Just include them in the whole process to what we ultimately decide to go with. Tell them why I'm leaning towards certain things, and then basically go nice and slowly so we don't overwhelm them. A lot of our programs are short-staffed. So in addition to not having additional money, we've got to think about that like the rest of you. So it's a 2-year pilot.
Okay.
Roll out gradually.
We have another question. Does the malnutrition screening look the same in rural areas and as urban areas? And where is this happening? Anyone who has malnutrition screening pilots going that include rural areas?
I can start. In Iowa, we have 6 different AAAs. And so again, we are farther out. This won't be incorporated in our state plan until 2026. So I had conversations with each of the nutrition directors, and within their agencies, their service areas, they identified a consumer group, a target population, what would work for them. So right now it looks a little bit different in the AAA service areas that are participating in screening. Some are utilizing malnutrition screening as part of a prioritization system for meals. Another agency is working to incorporate it in with case management or the Iowa Return to Community Discharge Planning. So right now it looks different, the pilots in each AAA. But we'll see what happens if it expands in the future.
All right. Anyone else with a final parting thought? Oh, Shirley, you're on mute.
I just want to address, because I mentioned a couple of times, there is no extra funding, but this is a very important issue. So the capacity building is very important. If you have at the state level or at our AAA level, you have the RDs on staff, then your attack can do a lot of services to create medical tailor meals. Also, you attack to other funding source, like I was saying, the Medicare Advantage, and also the CMS medical nutrition therapy. Those are funding is there. So you can try to consolidate different resources to build the strength for your organization to complete this process.
Thank you all. Thanks to the presenters and thanks to everyone who attended this webinar. Resources will go out after the webinar. Have a good rest of your day.
Thank you. Thank you, Laura.
Yeah.